Good morning, I'm Sara. I am a fourth-year cardiology resident at the San Cecilio Clinical Hospital in Granada, and I will present two clinical cases related to non-syndromic genetic aortic disease. The first case is a 29-year-old man whose father died at 25 from acute aortic syndrome, with a possible Marfan syndrome noted in the father's history, but without a confirmed diagnosis. The patient was seen in 2014 but lost to follow-up. We had no more information. In 2019, he experienced chest pain and general discomfort. Emergency treatment was initiated, leading to a diagnosis of type A aortic dissection with one entry tear at the valve level and another at the tubular ascending aorta, measuring a maximum diameter of 58 millimeters. The aortic arch, supra-aortic trunk, and descending aorta showed no dilation. An emergency surgery was performed using a Bentall technique with mechanical aortic prosthesis. The post-surgical recovery was favorable. In 2022, he was referred to Family Cardiovascular Clinic to screen for potential Marfan syndrome. The patient measured 163 centimeters, had a Marfan systemic score of 0, and lacked any other symptoms that might indicate connectivopathy. Nor does he present a phenotype that suggests anything syndromic. A family tree spanning 3 generations is created, revealing a novel presentation in the patient's father. Genetic tests for aortopathy were requested, and later the patient was asymptomatic, with CT and echo showing stable aortic condition without dilation. The control echocardiograms indicated stability of the aortic condition with no dilation of the aortic arch or descending aorta. The second case is a 42-year-old woman with no relevant family history. In 2020, while taking his dog for a walk, she started chest pain and self-limiting neurological symptoms, prompting her to visit the emergency department. An urgent aorta assessment was performed, diagnosing a type A aortic dissection with an entry tear in the tubular ascending aorta and a maximum diameter of 53 millimeters, which extended to the supra-aortic trunk. No dilation is observed in the aortic roots or descending aorta. Emergency surgery was performed, and a 34mm supracoronary dacron tube was implanted with a required and hybrid prosthesis of Thoraflex, with proper placement of the right brachiocephalic trunk and left carotid artery, but the left subflavian artery could not be reinserted due to impracticability during the surgery. In September 2022, we started monitoring our patient in the Familial Cardiovascular Clinic to evaluate for Marfan syndrome. The patient had a height of 166 centimeters, with a Marfan systemic score of 0 and no other data suggesting connective tissue disease, nor did she present any phenotype indicating syndrome origin. A family analysis spanning 3 generations was conducted, presenting de novo in our patient, and genetic studies were requested for this patient. In both the ECOS and the follow-up CT, dilation of the native aortic roots was observed, measuring 44 millimeters, accompanied by mild to moderate aortic insufficiency. The supracoronary tube showed no alterations, and the prosthesis was also without alterations, maintaining patency in the supraaortic trunks. The occlusion at the origin of the left subclavian artery was already there during surgery, and it was bypassed. The descending aorta was not dilated at all. Clinically, the patient was stable. What is common among these clinical cases? What they have in common is the result of genetic studies. Both patients show a mutation in the ACTA2 gene affecting the same amino acid residue of the final protein it encodes, specifically affecting arginine at position 258. In the first case, arginine is substituted with cysteine, while in the second case it is replaced with histidine. This could imply that the 258th position is crucial for the protein's correct function, and that various alterations in that same area may lead to similar clinical outcomes. Regarding the genetics of non-syndromic thoracic aortopathies, several genes are implicated in the disease. Of all these, the most relevant is the ACTA2 gene for being the most common. The ACTA2 gene, which codes for smooth muscle alpha-2 actin, has been linked to as much as 20% of non-syndromic familial thoracic aneurysm cases. Concerning the clinical signs linked to ACTA2 alterations, there are manifestations at different levels, but the most significant are those occurring in the vascular system, particularly those that manifest at the aortic level as aneurysms and dissections. This research examines 277 subjects with 41 distinct mutations in ACTA2, aiming to assess the clinical presentation, the management, and the outcomes associated with the first aortic event. The outcomes could have been either an aortic dissection or an elective repair of an aortic aneurysm. 48% of individuals presented with an aortic event, and among these events, 88% were aortic dissections, which had an associated mortality rate of 25%. That is to say, only 12% of aortic events were elective surgical treatment, of ascending aorta aneurysm. The analysis also looked at the most frequent type of dissection, with type A being the most common at 54% and a mean age of 36 years at presentation. Type B was less frequent, but the mean age of presentation was slightly earlier at 27 years. The accumulated risk of having an aortic event by the age of 85 was 76%, meaning that only 24% of individuals with mutations in ACTA2 did not have any aortic events during their lifetime. In this research, we examined if any mutations were linked to a greater risk of experiencing aortic events, and it turns out that such mutations do exist, leading to higher risk. For example, mutations that impact the 179 region and the 258 region, which is the area affected in our patients, were associated with a significantly higher risk of aortic events and also at younger ages. On the other hand, there are other regions that correlate with a lower incidence of aortic events, like region 185 and region 118. This all indicates that there are crucial positions in the functioning of the protein coded by ACTA2, the actin, particularly position 258. This work examines the molecular effects resulting from the alteration of the 258 region of actin. The molecular effects encompass on one side the impairment of actin polymerization, a decrease in actin's ability to form stable filaments, along with a disorganization of the cytoskeleton. As a result, the function of smooth muscle cells deteriorates, causing a reduction in the elasticity of the arterial wall. Additionally, the interaction of actin with myosin diminishes, leading to a decreased contractile ability of smooth muscle cells, which impacts blood pressure and vessel stability. Vascular structures. Regarding treatment, we must say that there is no specific treatment for patients with ACTA2 mutation. The same recommendations are followed as for other patients who also present an increased risk of aortic events, whether for other reasons or not. In these patients, what is essential is to prevent complications, and for this, intensive and periodic monitoring through MRI is recommended, and strict control of arterial blood pressure is paramount. Regarding the surgical threshold, we must say that it is lowered, and we consider surgical intervention for diameters smaller than those in the general population. We need to start considering surgical intervention when the diameter reaches a threshold of 45 millimeters. Aorta replacement is required depending on the extent of the disease, and we must say that patients with ACTA2 mutations often need multiple reinterventions due to disease progression. Particularly in patients who have had a dissection, there is a higher tendency for disease progression and the need for additional surgeries. In summary, ACTA2 is highly relevant to familial nonsyndromic thoracic genetic aortopathy. The mutations in ACTA2 impact actin and smooth muscle, leading to a weakened aortic wall and increasing the risk of aortic aneurysms and dissections. Not all mutations in ACTA2 are the same, and there are regions associated with a higher risk of aortic events, particularly at younger ages, such as in region 258. It is essential to prevent complications in these patients, and for that, strict monitoring through MRI is crucial, as well as aggressive control of blood pressure. Surgery for these patients has a somewhat lower threshold, and we must start planning for aortic replacement when it reaches 45 millimeters. Thank you all for your attention, and I hope it has been of interest to you.